we continue with Dr. Félix Guerrero Ramos from the Urology Department of the Hospital de Octubre in Madrid. Félix is one of the most expert in urothelial carcinoma in Spain. He is my friend, I know perfectly. And Félix, when you want, you can start your lecture.
Hi, good evening, everybody. Thank you very much for the invitation. It's a great pleasure for me to be here speaking. And I hope next year we can do this face-to-face and not online. So my talk here is about the role of biomarkers in the diagnostic process of bladder cancer. These are my disclosures. And these are the different scenarios we have for biomarkers in bladder cancer, both in non-muscle and muscle invasive, both in plasma or blood and urine, and with all of these purposes. I'm going to be centered on non-muscle invasive bladder cancer and on the role of these biomarkers, both on diagnosis and surveillance, as the most development is there. And I see the highest application currently nowadays here. As you all know, the cornerstones for diagnosis and surveillance in bladder cancer are cystoscopy and cytology. That's something we have been using for a long time, and this would be the current algorithm for anybody managing bladder cancer in any center in the world. So these are the cornerstones, cystoscopy and cytology, depending both at the diagnosis and also at the follow-up of the patient. And this is a repetitive algorithm for these patients. We know that the cornerstones have some limitations. Cytology has a very high specificity, but it has a quite low sensitivity, especially for low-grade tumors and for some high-grade tumors. Also for cytology, there's the handicap of the high rate of atypical results that we see every day in our daily practice. If we look at the EAU guidelines recommendations for the follow-up of non-muscle invasive bladder cancer, we see that it's easy that any patient with bladder cancer will undergo a high number of invasive procedures such as cystoscopy. Cystoscopies also have some limitations, which is specially centered on those patients of CIS, which will be missed, but the sensitivity, the specificity is also limited by the high number of false positives. Those lesions we usually see, we cannot tell if it's whether or not it is a carcinoma, and the patient goes at TURBT. Sometimes it's an unnecessary surgery for these patients. Also, cystoscopy has a personal price for patients. In this paper, we see that more than 20% of patients who undergo a cystoscopy have symptoms and had some adverse events which last for more than 48 hours after the cystoscopy. So, as we see here, lately, everybody has been, there's been an increasing interest on the patient perception in cystoscopy and the side effects and the patient journey through non-muscle invasive bladder cancer. One of these latest papers is from our center. We published recently that visualization seems to decrease the feeling of pain for the patients only in women, and also that those patients who have undergone several cystoscopies before have a better tolerance to cystoscopy than those who undergo the test for the first time. So after seeing the limitations of cystoscopy and cytology, there's also an important datum, which is that 60% of the cost of bladder cancer is related to the follow-up due to its high rates of progression and recurrence. We can use biomarkers with two purposes: to rule in, that is to confirm a diagnosis, in which case these biomarkers would need a high positive predictive value and high specificity. But on the other hand, we can use them to discard, to rule out, especially in the follow-up. We'll see this later. And in this case, especially, biomarkers will need a high negative predictive value, so as to, if we have a negative result, to be sure that patient is negative and we don't leave that patient on follow-up having a tumor. and also a high sensitivity. We'll go around this later. If we look at biomarkers from urine, as I said, I was going to focus my talk on this. There are different types of biomarkers in urine depending on what they analyze: exfoliated cells, proteins, mRNA, DNA, or extracellular vesicles or exosomes. I'm not going to go very deeply in each biomarker, but I'm going to name some of them and characterize some of them very lightly, because if not, this could be a nightmare, as there are more than 100 biomarkers currently for bladder cancer. If we look at exfoliated cells, one of these biomarkers would be the classic cytology, but going to the newer things we have, one of the classical ones is Eurovision, which is, I'm going to show to you which of them are FDA or European approved. And also, Eurovision is useful for diagnosis and for follow-up, but in conjunction with other standard diagnostic procedures. For protein biomarkers, we have one of the most popular is ADX Bladder, which is CE approved, but not FDA approved. Also, it uses MCM5 protein, and the clinical application would be also diagnosis and follow-up. Looking at messenger RNA, we have several biomarkers which have been commercialized, like Expert Bladder, which is also for the diagnosis and the follow-up, also approved by the European CE mark, but not by FDA. And we also have CX Bladder Detect Monitor, also for diagnosis and follow-up. None of these organisms have approved this CX Bladder test. Some of the most popular and used biomarkers are those which analyze DNA in terms of DNA methylation, microsatellite alterations. And one of the most important of them is Bladder Epicheck. This is the one we use in our clinical practice, and I will tell you our experience later. It's CE approved, and it's pending an FDA approval. It's used for follow-up, and it analyzes the methylation of 5 or 15 genes related to bladder cancer with a real-time PCR, with a dichotomic result of positive and negative, and also a score of which 60 or plus is considered positive. Euromonitor is a more recent test which has been commercialized, also used for bladder cancer follow-up and diagnosis, and Eurodiag is the other test which is based on DNA technology. The last kind of biomarkers are those extracellular cellular vesicles, which we don't have. There are a lot of them. Here we can see that most of the trials are mainly exploratory. The methodology between them is quite heterogeneous, and most of the results are preliminary with no validation cohorts. But as we see here, there are lots of them, both in urine and blood, and also in the tissue, in the urothelial mucosa, with different outcomes that they predict. Also, they can be used as diagnostic and therapeutics, and these exosomes are in the pipeline, and some articles call them like the rising star in bladder cancer management. There are many, many more kind of different biomarkers. I'm not going to speak about all of them, but here you can find lots of articles, reviews with all the different biomarkers, depending on where you find them, the technology that they use, sensitivity, specificity, and so on. As I said before, there are different clinical applications for biomarker tests. We were seeing that some tests can be used to rule in, that is to confirm a diagnosis, and some of them can be used to rule out, to discard the diagnosis of a recurrence, for example. So those tests which would be useful to confirm a diagnosis, with the blue star, you can see them, that could be used at the diagnosis of the disease or during follow-up if you want to confirm the diagnosis of a recurrence. For me, in the follow-up of non-muscle invasive bladder cancer, there is a higher importance for those tests who can rule out or discard the diagnosis, as you can avoid unnecessary and invasive procedures. For example, you can use tests, and now they have been admitted in the EU guidelines in 2021 that in certain scenarios you can use a test replacing a cystoscopy, and especially for surveillance, where you can avoid cystoscopies to the patients, as I said before, with a high negative predictive value. I mean, if the patient has a negative result, you can be quite sure the patient has not a recurrence, so you and the patient can be quiet and go on for the next appointment. Regarding the RT-BT, as we know, according to the EU guidelines, RT-BT should be done in all T1 tumors and other certain cases where you cannot make a correct diagnosis. But those patients with T1 tumors who undergo a RT-BT, and this is a place for some biomarkers to get here, if you can have a biomarker to predict the persistence of tumor there, you could avoid some procedures in these patients in case the biomarker tells you there's no residual tumor, you can directly go to instillations. So we're going to see a comparison of biomarkers depending on if they are used for ruling or if they are used for ruling out or discarding unnecessary procedures. The most relevant tests that have been results published and validated results for diagnosis are Eurovision, ADX Bladder, Expert Bladder, and CX Bladder. You can see similar specificities, which are higher maybe for Expert Bladder and CX Bladder, and no positive predictive values reported in the literature. If we go to the main scenario, in my opinion, which is the follow-up and surveillance, where most patients undergo many procedures, we can see that the most relevant results are for Eurovision, ADX, Bladder Expert, CX, and Bladder Epicheck. We can see here the table with the overall results, both in high and low-grade tumors and in the high-grade tumors, which for me is the most important and relevant population, as are those patients whose tumor could progress and limit their survival. So here you can see that just 3 of the tests have a negative predictive value reported, with very, very good numbers over 98, 99%. In our experience, we use Bladder Epicheck in our private practice. We don't have it available in our public practice. We chose Bladder Epicheck due to this is a review of all the published studies with Bladder Epicheck, a very high negative predictive value, but also because its results are not altered with microscopic or macroscopic hematuria, with infections, with instillations, that are things that are common in this kind of patients. So far, we started in September 2019, and so far we have obtained more than 300 samples. We can highlight the ease of use. It's easy just to get the sample of the patient, send it to the central laboratory, and then you get the results on your website with your username and password. Of course, if we have a negative test, we follow up these patients, and if we have a positive test, the patient will undergo bladder biopsies. We don't go for cystoscopy, we go for bladder biopsies. We think we have a better vision of the bladder with the resectoscope, and in the patients where we have any other, we're not sure, some patients will also undergo upper urinary tract imaging. Those so-called false positive, which are not so false positive, you're gonna see why. I mean, those patients who have a positive test, they undergo a biopsy and that's negative. In our experience, those patients are at a higher risk of recurrence, as it has been stated after 6 to 12 months. In most of the patients are recurrence. Some of the patients have had a high grade, or even one of them a low grade neoplasm in the upper urinary tract, and some of them, which are more recent and have those positive results with a negative biopsy, are undergoing an even closer follow-up once we have stated those recurrences in the first months after this situation. On the other hand, I've showed you our experience in our private practice, in our Hospital Octubre, where we work with some people from CIEMAT doing translational research. We have also used microRNAs to predict the presence of bladder carcinoma. So there are 5 microRNAs, which you can see on the left of each graph, the results for a tumor tissue, and on the right of each graph, the results for normal tissue. These microRNAs have showed to predict the presence of bladder cancer in that tissue, and it has also been shown both in urine and in blood of these patients. After the study of the validation court, all these results are pending from a patent and will be published soon. Also in urine, you can see that the combination of those microRNAs, both in tissue and urine, can differentiate that those patients with bladder cancer from those patients, those healthy donors, which have a healthy urothelium. The results we have obtained with this are with over 90% of sensitivity and specificity, and this could be a potential new biomarker, which would be added to all the rest we have. And after more studies and more development, they could get to clinical practice. In this sense, we also have some data with these biomarkers and other things on BCG response prediction, but unfortunately, we cannot still tell anything about this data, but soon we'll have some data, which is the doctoral PhD of one of my colleagues on the prediction of BCG response in patients treated with BCG. So my take-home messages, and to conclude that there's no perfect biomarker, as almost everything in life and almost everything in medicine. We have a very exciting scenario in front of us, and soon we will get many more biomarkers commercialized with more validation studies. And one of the keys is to choose the correct and the right biomarker for each situation we have and for each patient we have: diagnosis, follow-up, prediction of recurrence, muscle invasive, non-muscle invasive, even in the future variant histologies, as Professor Beltran said. Last week we were speaking about this in another workshop, and somebody asked me if the biomarkers would be used in the future. My response is that the future is here, and we currently use biomarkers, and they can be used in clinical practice. And also, it's important as a conclusion to highlight that not everything is as nice in the lab as in the real world. So we need a biomarker which is easy to use, which is inexpensive, and which is operatively to use, knowing that we have a lot of patients every day in our clinical practice. So those biomarkers where you need a high infrastructure are not really translatable to the clinical practice. And everything, all these things I told you, will also be the condition by what we think and choose the correct biomarker for the correct person, and also the interpretation of us as doctors. Thank you very much. And well, the discussion will be later, I think, after Dr. Duran. Thank you very much for the invitation and for your attention.